We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. All right, welcome to the podcast this morning. We are so excited to have Brad Klemetson join us. He is a doctor of physical therapy and owner of Mint Physical Therapy. He owns 8 clinics all the way from Ogden down to Provo in Utah, and he specializes specifically in auto accidents and workman's comp. So if you've been injured at work or you've been in an auto accident, this is the podcast for you. We're talking all things MRI and how MRIs can scare you and not be helpful. And a lot of us think about MRIs or imaging x-rays as kind of the gold standard to tell us our diagnosis. And sure, they are useful tools, but sometimes they can scare you so much and actually increase your pain. So we're going to dive into all things imaging today and how we use that in the clinics and how they can be useful for you. But just a little bit of background on Brad. He has spent most of his career treating neck pain, dizziness, headaches, migraines, numbness, tingling going down your arm. He's exceptionally good at translating imaging reports into something patients can actually use, which adds clarity instead of panic. Because when people look at their MRI and they see stuff, there's a lot of words that are confusing, and that is something he's really good at, is explaining those things to decrease people's anxiety about it and fear about it to get them back to what they need to do. He's also certified in what's called functional capacity evaluations. So you're injured at work, you come in, you get a very thorough exam, usually about 2 hours roughly, and sometimes 3 hours, but they go really in depth into all things to figure out what your capacity is to lift, to squeeze, to lift overhead, lift from the ground to the floor, and it breaks down all these things to make sure you're ready for your work and you're over prepared for what you're going to do at work. So he's got some unique certifications in that. To help people really navigate, real world pros and cons and treatment options without fear and anxiety. So today, we're going to expose the most common myths. We're going to explain how these findings can give you very simple, evidence-based ways to move forward with confidence. So, Brad, welcome to the podcast.
Thanks for having me on. I'm excited to chat about this.
You have your own podcast. We've known each other for a while. It's time we have a conversation.
Yes, it is. This is going to be good.
Tell me, as you think about all of the different cases that you've treated over the years, and we talk about MRI, what's the best question patients should be asking themselves when they get their imaging?
Yeah, I love that you started there. I think they need to be asking, how does this correlate with the symptoms that I'm having? Right.
So give me an example of what you're talking about.
So we're not meant to be Barbie dolls, right? Especially on the inside. Things might look a little bit messy. I think the best example, and most of the doctors, Dr. England here in Salt Lake is a huge fan of this. Dr. Church, several of these doctors will teach all their patients the same concept, is that you get an MRI and it shows a bulging disc. Does that bulging disc mean that it's causing your symptom? That it needs surgery? Bulging discs come and go every 90 days. So everybody has
and really
1 to 2.
For everyone, right?
Yeah, for everyone at all times. And they've done studies on this, people without back pain ever having any symptoms, and they've got several bulging discs. So is it correlated to my injury, and is it going to go away on its own, or does it even need surgery? It's how am I moving functionally more important than what does my image look like?
Yeah, because the thing is, we get these MRI reports, right? And it's like degenerative changes, disc height issues, right? Using all these scary words, herniations, bulging, people start to imagine in their minds this jelly donut that we all learn. People say that you move one wrong way and the jelly's just going to squirt out the back, right? Talk to us about that. Like, let's abolish some myths with just the jelly donut concept for a second.
Our bodies aren't weak, right? They're vulnerable, but they're not weak. We've got a lot of strength and we can trust our bodies. And when things look a little bit off, they're meant to bulge and move. One of my favorite concepts to teach people is that you're a half inch taller in the morning than you are at night. Because at night, you lay down, you sleep for 8 hours, and your spine decompresses and fills up with fluid. So when you stand up in the morning, you're taller. And then throughout the day, the pressure pushes that back out. And our bodies are designed to function that way on purpose. Yep. So we're not a jelly donut. It's not supposed to look pretty. And if it doesn't correlate to the symptoms you're having, then it's most likely not a cause. A bulge disc at L2 is not causing numbness in your right thumb.
Yeah.
So you've really got to look at the big picture.
You know, I remember in school, we, in the human dissection portion of anatomy, we took out a disc, and keep in mind, this was a cadaver. Someone had passed on, and we took a disc out of a spine. And I remember taking that scalpel and pushing it into the disc, and scalpels are really sharp, as we all know, right? I couldn't even get the scalpel into the disc, right? So on the outside of a disc is really strong, right? You have that really strong structure. It's a ring. And then on the inside, things are softer. People interpret that as it's jelly.
Yeah.
But the component in the inside is really thick. Think of it as like really thick tar. It doesn't just like squirt like, juice coming out of an orange, right? It's very thick. Think of it as like almost like a tire. Like it's soft, but it's really gooey and hard packed. But the discs are really, really strong, right? So what causes them to bulge? Essentially movement, right? And people have these bulges all the time. And it doesn't mean it's correlated with their pain.
Yep.
I mean, how many times have you seen, we measure things and we understand that maybe it's a C7. It's in the cervical spine, the seventh vertebra down, and we correlate the symptoms with the C7 segment. But then on the MRI, all of a sudden we see all these changes at C3, C4, and people are like, I just have a bad neck. How many times have you seen this?
All the time. All the time people come in and I've got a bad neck, or they talk about they're 40 years old and back when I was 16, I got hit by a baseball or I fell during football and that's what's causing it. And we think our bodies are more vulnerable. I love your description of the disc. It is solid. If you can't puncture it with a scalpel, it's definitely not a jelly donut.
Yeah. And I've talked to surgeons. I've not sat in the surgery to understand how the tissue really feels when it herniates. I've been told it's a thicker substance, but when it does herniate, it kind of solidifies, but it's soft, a little bit softer material, right? And that's where it can become very toxic to a nerve. The chemical components can leak out and irritate the nerves and send those signals either down your legs if you're low back or down your arms if it's your neck. But the tissue can also push on a nerve too, right? But when we see these things on an MRI, what we're really looking for is what correlates with your symptoms, because the symptoms that we're measuring are telling a story. So we're identifying based on, let's just go back to the C7 segment, right? What are the symptoms that you'd see of a C7? How would you identify that?
Yeah, so with you're looking at the patterns of that nerve, both from a neurologic, more a sensation aspect and a muscle activity aspect.
So you mean like the feel, like the sensation of touch?
Yeah, so you're feeling, people talk about the tingling, numbness, pinprick sensation, right?
Yeah.
Or the strength. So you got to look for both. And if you have tingling sensation, the feel that's consistent, that's a bigger concern. That's where we might be going in and looking at maybe ordering an MRI. If they're losing muscle mass, atrophy, that's an automatic red flag. We're looking for that.
So you lose both touch, light touch, so it feels different, numbness, tingle, but also you lose motor control, which is the muscle activation, which the muscles start to decrease.
Yep.
And you're saying that we're going down the MRI route in those cases.
Yeah. And that's one example of some of the red flags that you are going to want to go and get that MRI. But back to your question, what is the presentation of that C7? And then what you see that on the MRI, and then you see that in functionally what I'm feeling and how I'm moving, so that you're looking at all of those components.
Give us the basics about dermatomes, myotomes, and deep tendon reflexes.
Yeah.
Like, very, very simple.
Yep.
I mean, I remember in anatomy when we learned dermatomes, it made no sense in my mind. So we're going to really break this down for everyone, because those three things will tell you a story of where the problem is. So give us just like a back of the book summary of those three things.
Yeah, those are some big words, right? Dermatomes is what your sensation is on the outside. Myotomes is which muscle groups are affected. And then deep tendon reflexes, DTRs, are certain spots in every doctor, every EMT, ER, they all know to test these things because it can give you some insight on to your upper motor neuron issues or lower motor neuron issues, right? So let's start with those reflexes. That's your tendon feels an immediate stretch and it responds by contracting. So everybody knows this one when you hit right below your patella and you kick out, right? That's one of those reflexes, but you have them all over your body. I actually thought that was so cool in school to learn about, because I knew about the knee one. I didn't realize that it was in your elbow, your wrist, on both sides, pretty much any muscle. If you can isolate it, you can get that reflex.
So which one are you going to test for C7? If you believe that there's a disc problem at the C7 region, where are you going to get the closest for that? We test these different deep tendon reflexes to determine, oh, that's a C7 level, right? And most of the time we're actually not testing them, right? Because we don't, based on the history, we don't anticipate there's an issue, right?
Yep.
But if there's numbness, tingling issues, like we're going to go to deep tendon, right?
Yep.
So the levels, you could pull up a chart, right? You don't know these off the top of your head. I forget them too. Pull up a chart and it's like, okay, what level was that again? But then we match them up, right? But then we might not run into that issue again for 6 months. And it's like, well, I studied this like the back of my hand in school, but do I memorize them? I had them memorized at one time, but I'm going to forget them over time because you don't use them every day, right? So you might have to look up a chart. Okay, C7 tricep, right? And then we have the different patterns. Break down dermatomes for us.
Yeah, so dermatomes are a lot easier to follow when you put someone in quadruped. So it took me a while, like you were saying in school, you're like, this is so frustrating, right? But once you put somebody in quadruped, you can actually see the lines.
On their hands and knees, right?
Yeah, hands and knees. So there's different patterns, like your shoulder is C5, then down the outside of your arm, C6, down the middle, C7. And those are the different levels in your neck. The nerves coming out of your neck go to the skin, or the sensation to touch, heat, pressure at those different parts of the body. On your leg, it's the same thing.
So you're saying there's a certain section of the skin that the C7 nerve sensation feeds to.
Exactly.
So if that section is numb, we know it's correlated with the C7 nerve root to identify that there's a disc or something wrong with that segment.
Yeah, I think one thing that, to break it down a little bit, that might help people understand is when you look at the nerve root, like what you just said, that's right where the nerve is coming out the hole in the spine, right? It's called the fossa on the side, or there's another term for it, but they name all the facet joints and everything, have a lot of names. But right as the nerve comes out, you've got the nerve root. Then it branches out.
It's really turned into an anatomy lesson this morning.
But you need to know, where is that pressure? Because people will come in and they're like, I have carpal tunnel on both hands, and they're going to do surgery on both sides. Mm-hmm. Is that the right answer?
Only if it lines up, right?
Only if it lines up. And how often is it both hands? If somebody uses a jackhammer at work, maybe. But most often, if somebody comes in and they're like, both my thumbs are numb, then I'm looking at the neck, because your left shoulder doesn't affect your right thumb.
Yep.
And so knowing that nerve root, then as you go out, it splits, and then it becomes part of the brachial plexus, which is just a bundle of nerves right in your neck into your shoulder. And knowing where it's compressing will give you different symptoms. So if it is an isolated part of your arm that's numb, that's nerve root and inside the spine. It's not going to be a brachial plexus compression, most likely.
Yeah. I love it. So going back, we got the 2 down. We got deep tendon reflexes. We got dermatomes, which is the sensation in the skin. So if my C7, I got the elbow, C7 sensations on the front of the arm. What's the third component? Myotomes.
Myotomes, muscle activation. There's a big difference. This bugged me for years. You've got myotomes and MMTs, muscle manual tests. And everybody I talked to was like, they're the same thing. They're the same thing. And then I took a dry needling course and they broke it down. Myotomes is the ability to activate and sustain a muscle's in any joint.
Yeah, they're 2 totally different things.
Yeah, muscle test is multiple muscles sometimes doing an activity. My elbow flexing is a muscle test. But if I can isolate just my bicep, and does it sustain that contraction? So you've got like your C5, C6, C7 going to different muscle groups in your arm. Your lumbar spine goes to different muscle groups in your leg.
Yeah. And this is so interesting because we're going to tie this back into MRIs. If you get an MRI, say you go see a physical therapist or you go see an orthopedist or a spine surgeon, and they say all of your symptoms are correlated with the C7 level. And then we get the MRI and we see nothing at the C7 level. Are we going to operate on C7?
Most likely not.
No, it's likely not, right? It's not matching up. But if we see a huge disc herniation at C7, you're not progressing in your therapy. You're actually getting worse, more numbness, more atrophy. What are we doing then? Most likely procedure.
Laminectomy, discectomy. We've got to remove some of that pressure on that nerve because the nerve needs to breathe.
Yeah. And what do we, I mean, you think about like you could have bulging discs at the higher level. What do we do with those? And how do you educate patients on that?
What do you mean by that? Bulging discs higher, like above
the C7, you don't see anything. But all of a sudden you see all this other stuff and they're like, oh, C2, 3, and 4 are all just so bad.
Yeah.
How do you have those conversations if they don't have any symptoms from that?
Yeah, the conversation goes twofold. One is let's assess how you're responding to different treatments. We start conservative, progress towards more aggressive. And then second is understanding that bulging discs and facet joint issues and pressure and injury above can affect the levels below. Mm-hmm. So if somebody has a bulging disc at C7, but all of their symptoms say C2, I don't think C7's affecting C2.
Absolutely.
But the other way around can happen. And especially in the lumbar spine, I know we're talking a lot about the neck, but the lumbar spine has more of this happening because your spinal cord stops at L2, L1, L2.
So this is in your low back, right?
Yeah.
L1, L2 is just kind of the first part of your low back. But yeah, totally.
And then it becomes your cauda equina. That's a fancy word for horsetail. Mm-hmm. And it's just all those nerves splitting out. So if you have a bulge at L3, it could affect L4, L5, S1, any of those nerves because those nerves are just sitting there traveling down the spine.
Yeah. So let's kind of go back to a few of these studies that we talked about for a minute. You know, I'm just thinking about, I've seen so many studies, like literally, I don't know, 15, 20 really good randomized controlled trials, systematic review. That just means that they're really good studies. Like they really go in depth, they're peer reviewed, they're blind, like all these like buzzwords that we say in the research world. But, you know, these studies that they do on people that don't have any pain at all, how many of them are showing abnormal findings? Like, and you don't have to be very specific on them, but like, what are we talking about here? Is it a small number, a large number?
So I used to have these numbers memorized because I use this all the time to help people understand your MRI is not as scary as you think it is. And I don't have them memorized perfectly, but I have the ranges. So when you're 20 years old, you have a 30% chance of having a bulging disc with no symptoms, a severe one.
Absolutely.
Right?
Yep.
When you're 50, that chance goes up. And I don't remember the numbers. It's like 45% chance. When you're 80, it's an 88% chance you're going to have degenerative disc disease without any symptoms. And a 78 or something, don't quote me on those numbers, but a very high
I've seen
percent
the
chance.
tables. Every study that I've looked at is almost identical.
Yeah.
They can replicate it consistently. And
Over
we're talking
and
like
over.
5,000 people in these studies. This is not just like a good 20 people. This is big numbers we're talking about. And, you know, some of the, 70 to 80 year olds, you got a lot of stuff going on.
Yep.
Does that mean you're going to have pain? No. right? These studies that they've done are all on what we call asymptomatic, meaning they don't have any pain, don't have any symptoms, and they happen to have 80% degenerative changes, right? Or 80% of those 70-year-olds have these degenerative changes, but it doesn't mean they have pain, right? So how does imaging unintentionally create this damage story? Let's talk about that for a minute.
I love this topic because we need to know when to order it, when not to. I'm not anti-MRI by any means, but it creates this damaging story because...
Yeah, even I would say we're pro MRIs. We're pro imaging, but intentionally doing it the right way, right?
Yeah, you go to the ER or your doctor's like, oh, you have shoulder pain, let's get an MRI, right? Small tangent, and we'll get back to that, but my favorite thing is insurance is saying you got to do 2 weeks of PT first. Super frustrating in some cases when they really need that MRI. Let's go. Mm-hmm. But in some cases, they're right. It's because we're getting an MRI when it was too early. So to answer your question, the MRIs can be damaging because they're showing you something that might appear ugly, or the radiologists have to use these ugly words.
It's like a freckle on your face. My MRI would look pretty bad.
Yeah.
You know what I mean? I got a lot of freckles.
No, freckles are great. But
yeah, like their job is to point out all the freckles, though.
That's their job. Tell
all
you everything.
The imperfections that are happening on the MRI.
Yeah, so I like to compare it to a telescope. If I'm looking for my keys in my family room, I don't pull out my telescope to zoom in, right? So when we have an injury, why are we pulling out a telescope as the very first thing to dive into every molecule that might be slightly off, instead of taking a look back and looking with our eyes first?
That's a good insight. I love that. So how does it actually create damage for the patient?
So it's what it leads to. It causes fear. The research shows that you're more likely to get surgery if you get an MRI. And some of that is because you're getting unnecessary surgeries, right? I don't remember the exact number, but there was a study in 2016 that showed that something like 90% of back surgeries were unnecessary. That physical therapy, it actually said in the report, physical therapy would have been just as good or better.
Yeah. 90%
of a $6.2 billion industry.
Yeah.
And it's because we got an MRI, and I've been injured before a lot of times.
Yeah.
Right. I thought being a PT, I was exempt from that, but I'm not.
I don't get injured, so I don't think that.
It's just me.
I'm just kidding.
But I get these injuries, and when I'm injured, and I've had some severe ones, torn an ACL, I'm like, fix it, just fix it. I don't care. All those rules go out the window, right? Some of it's the pain, some of it's the fear. So if I had a lot of pain, I can't get up and walk, and I get an MRI that shows me this bulging disc, I'm like, cut it out, fix it, as aggressive as possible because of the fear and the pain. When some different approaches, like McKenzie approach, is a really good approach that might fix you in a couple weeks, save you from a surgery that leads to long-term damage.
Yeah, and for those that don't know the McKenzie approach, it's a treatment model that we use in physical therapy to progressively go through exercises that change the mechanics of the disc in the spine and become less sensitive over time. So essentially, if we were to simplify that, it's moving the spine in various motions up to pain tolerance and then gradually adding more.
Yep.
Is there anything else you're going to add to that?
I want to give you an example of a patient that made, this is why I'm so passionate about MRIs. Right out of school, actually I was still in school, it was my first rotation, Stansbury Park with Mountain Land, and we had a patient come in, 8 levels fused in his back. I'm a student, so a lot of this is new, a little bit scary. He's 80 years old, 8 levels fused. And then that was Tuesday. On Friday, another patient came in, 8 levels fused, and I just sat there really confused, felt like deja vu. My instructor kind of looked at me and he's like, deja vu? He knew it. It was really cool that he knew that. And I was like, yeah. He's like, yeah, that was Tuesday. I was like, okay, my days are getting mixed up, right?
They what happens as a student, for sure.
Yeah, it does. It's a lot of information. So there's both of them were in their late 30s, early 40s, got their first surgery. And then it causes more wear and tear above and below those joints.
Let's just talk biomechanically. Why does that actually happen? Like, say, because there's articles that say that, it doesn't do that, but biomechanically it has to. Give us some just like background, like why, if you fuse one level, why does it demand more energy below and above?
because your spine is like an orchestra, everybody moving together. And if one person's offbeat, you feel it, right? If that person was silent, that'd be great, right? But it's not silence, it's offbeat. It throws off everybody. And the people closest to that person offbeat or out of tune feel it and hear it the most. So the levels right above it and below take the most impact, and then you go another level away, they feel some. 3 to 4 levels, I've seen most people don't have as much damage happening there initially.
Yeah, so essentially the load that they were intended to take up at that segment now takes up twice as much, because the one below it is now not moving. So it's demanding more motion and more load and more impact at that segment. Yeah. And you can't dispute that. That's purely just biomechanics. It's just the way it has to happen. So yeah, I mean, in our world, we do see one leads to the next, right? Even with microdiscectomy, if you can avoid fusions and microdiscectomies at all costs, do it. There is a place for them, and we'll talk a little bit more about that. But anytime you change the natural mechanisms of your body, it's gonna have a down trickle effect, right? Say for instance, you just trim a disc. It's not really trimming; they kind of chomp it off, but it decreases the disc height, right? It decreases how much volume of tissue you have there. You talked earlier about how at the end of the day you have less volume because the fluid absorbs into your body, and then your discs fill up with fluid at night. But you have less disc height after a microdiscectomy, so you lose volume. Like I said, if you have these symptoms that we talked about earlier, absolutely necessary. But if they're progressing in therapy and you are consistently getting better, don't do the surgery, But let's give our listeners an idea of what is the right time for imaging. How do we make those decisions to say, go get it or don't go get it? We know getting it too early it can be detrimental, but when do we pull that trigger to say it is time?
So the very first thing is when they're not progressing with physical therapy or any kind of conservative care. So they've worked with physical therapists. You've told me stories about patients that have gotten worse as you're doing the right things. And I think that's amazing that you're paying attention to that and humble enough to realize, okay, I need more information and refer out. If the patient's getting worse or their symptoms aren't changing with conservative care, we need imaging.
Yeah. And then tell us about what you use as kind of red flags.
So red flags would be anything that the big ones a lot of people know: pain that wakes you up at night, you're gaining weight or losing weight unexplained, numbness and tingling, especially that's progressing and getting worse, muscle mass loss. I've had patients come in and their thenar eminence is gone. It's like, okay,
it's like muscles in their thumb.
Yeah. And another really big one is cauda equina syndrome, right? That's when you have that pressure on the spine and the low back, and it's cutting off blood flow to those nerves, and you lose control of bowel and bladder suddenly. Those are signs. Get into the ER, get an MRI, and be more aggressive about it.
Yeah, and I love what you said. Like, if you're under the skilled care of a physical therapist or any healthcare provider, and I would lean obviously more towards physical therapy because we're the musculoskeletal experts in that area. But ultimately, if you're not progressing within a period of time, 3-4 weeks of skilled therapy, and it's getting worse or plateauing, like you're not getting better, that is a good time to order imaging. And if your therapist is not ordering it, recommend it, right? Or maybe find a new one, because that is important. And especially if you have these neurologic symptoms, the numbness and tingling, the bowel and bladder, like not able to control your stool or your, going to the bathroom either direction. But those are really important things because they can become permanent, and if we don't catch them early enough, they can become permanent for forever.
Yeah.
So
it's very severe, and it's important, like you said, to advocate for yourself. Patients need to advocate and make that suggestion. Some physical therapists are so overrun. I've talked to some PTs who have to see 8 patients an hour, and they're just trying to survive the day.
Yeah.
So advocate for yourself, speak up, ask, and it's okay to get second opinions. It's okay to talk to 2 doctors. I have no problem with my patient seeing another physical therapist and getting another opinion.
Yeah, I mean, ultimately, we got to be okay with that. We have a whole procedure that our clinicians follow in the clinics, and it's step by step. We call it the plateau procedure. So if your patient is plateauing, here's the 1, 2, 3, 4, 5, 6, 7 steps in order of what you should do. And one of the first one is talk to a colleague, right? Talk to someone else in the clinic, get their viewpoint, just have a discussion, and then attempt to apply what they're saying, right? There might be something you're missing. Another step is have that colleague actually see that patient with you or on their schedule, right? Just get that second eye, you know. Another component early on is go study it. You might have forgot something, and then implement what you learned, right? So these are all just components that we add on before we refer out, but they got to happen quick. This doesn't happen over a 10, 12, 15 week process. We're having these conversations and thought process at week 3, you know, because we need to make decisions faster as therapists, you know, as primary care role. So let's dive into a kind of a shift with these imaging. We're going to talk about interpreting imaging like a pro, right? And just kind of the basics. We're not going to go into all the specifics. We're not here to be radiologists. We're not here to, you know, go into interpretation. We're just saying the interpretation's been made. How do you look at the report and say what's helpful, what's not helpful as in the public? Most of the time I tell my patients, don't even read it. I'll read it. I'll call you. I'll break it down for you, right? But let's just talk about some things that you've found helpful over the years as a clinician first, and then we'll talk about the patient.
Yeah, I think the things that have been helpful for me is studying the topic, looking at imaging, go and do my own due diligence. I've talked to a lot of physical therapists. They're like, I don't deal with that because I don't know it. If you're going to be a clinician and not just an exercise specialist, then you need to put in that effort to learn it. I've talked with a lot of radiologists in general, just chatting and learning from them, but even calling them up, I get the results back and I call them up, talk about what I'm seeing, what I'm not seeing that I thought I would see, and just to learn from them, or sometimes collaborate with them.
I love it. That's good insight, because the thing is, the more MRIs you look at, the more reports you look at, the better you get at reading between the noise, because you really want to eliminate the noise and look at the signal. So the noise is all the fluff. The signal is what is on that report that aligns with the symptoms. So if we have numbness, tingling at the C7 level, our eyes are going to C7 first, right? And then the other stuff, you know, for me as a clinician, it's kind of just white noise unless it correlates with another symptom. And then I'm like, makes sense, right? Because it could be, you know, say we're looking at the shoulder and we're looking at the rotator cuff, and I think that it's one of the rotator cuff muscles. And then all of a sudden, there's a labral tear, right? I might have been off with my diagnostic measures, right? It's like, I thought it was the supraspinatus rotator cuff muscle, the top one, but right next to it is the labrum, and the bicep tendon feeds in the labrum, and I got a tear there. Oh my gosh, I totally missed that, right? And you could see how you'd miss that, right? Because it's so closely correlated. But, you know, those are some helpful tips in reading MRI. Just make sure it matches the symptoms. Anything you'd add to that?
I just add, everything you said was great, but I would add retest then, right? Because those tests aren't perfect, and we're not perfect humans either. We often test to put somebody in a box that makes sense to us.
Yeah.
I treat a lot of headaches and migraines, so anything that's close to that, I want it to be a headache or migraine because I'm human. So I have to remind myself to back up and assess the person, not my box.
Yeah. So let's just talk about patient advocacy for a second. I loved all those thoughts there. How can clinicians and how should they talk to patients about these findings?
I think that it's good to, like you said, break it down and show them what's important. But then I would follow that up with asking them what other concerns did they have about it? Because even if you tell them not to read it, they're likely to read it.
Yeah.
Or
that's kind of like
throw it
saying,
into AI.
Hey, Brad, don't think about a pink elephant. What do you think about
pink elephant?
Yeah, like immediately. Yeah. Like you say, don't read the MRI. What are they going to? They're going to go read the MRI. You know what I mean? But yeah, give me your other thoughts.
Yeah. So ask what concerns they had so you can discuss it. And they're like, it says degenerative disc disease. I'm like, yeah, that's called being human. Like, let them know, because some doctors are brushing by it, or some doctors don't have time.
It's like having a freckle on your face.
Yeah.
Degenerative change. Yeah.
You have it. It's normal. It's fine. And then I would say break it down. Help them understand word by word what's going on and what it means and how severe is that. When they see moderate disc bulge at whatever level, they're going to be concerned about that. But when you can educate them that there's this much space for the nerve and that bulge is taking up to 50%, then there's still space there. Your nerve isn't being cut off by 50%. Yeah. That would be severe, right? The nerve is okay. And how severe is that? It's probably going to go away on its own in 3 months.
Mm-hmm. Which the majority of cases do, right? I have one case in particular. I've seen this, one of my friends for, a year and a half. And he just keeps having these recurring issues. And we just got his third MRI. And I compared it to his first MRI, and he had a 4-millimeter bulge at a year and a half ago. And now he had a 5-millimeter bulge, the same segment. In the clinical world, we look at that and say, well, it's not absorbing. It's not doing what it usually does, right? And that would be a good case. We're going to try to manage it the best way we can with injections and see if we can, calm that down with potential to reabsorb. But I don't know the likelihood of it reabsorbing because it's been a year and a half, right? And it's been recurring. So there's some cases that just don't naturally heal. They kind of just get stuck in that space. And those are typically the ones that we operate on and do what's called a microdiscectomy, where they kind of go off and take that tissue out. But really interesting things. So anything else you'd add to clinicians talking to patients about imaging? Anything else?
I would say that we need to tone it down. We need to help reduce their fear. So if somebody, be realistic, right? My nephew just tore his patellar tendon, and the athletic trainer's like, you need to go to the orthopedic surgeon now. And I'm like, hey, calm down, right? And I show up at his house. Don't put him in panic. Yeah, don't put him in panic. I showed up at his house. I was like, actually, she's right. She was right. Yeah. So it's okay to be aggressive. Get the referral. Refer out. Get rid of your ego. Refer to the specialist that they need to see. But what if it wasn't that bad? What if it was just a simple sprain of the knee and she's freaking out that we need surgery? He got surgery this morning. So he tore it 2 days ago, and it was an avulsion fracture. And it's a really good thing that he got in quick and fixed it, because it could have been bad. Yeah. But at the same time, there's other ones where it's a simple sprain and we're getting an MRI that's going to show him it's a sprain, and it wasn't necessary. So help people calm down, but be a good enough clinician to know when it is severe and when it's not.
Yeah, absolutely. I think that's really good insight, because you can have this like pendulum of just diminishing or gaslighting patients, right? It's like, that's not an issue. Like, it doesn't matter, right? We see that all the time. There's got to be this balance of hearing people and listening to their concerns and their worries. And then once we seek to understand, then educate, right? Not reverse. Because too often we just start educating on what we think the patient needs and wants. But a majority of the time, they have completely different questions. But if we just pause as clinicians and just listen and say, what is it you hope to understand about this MRI? What are your concerns? Then we can seek to understand, and then we can just answer what they want, rather than just vomiting information on them that they didn't even want in the first place.
I like the way that you said that, seeking to understand, and the question you asked, the way you phrase that is perfect. Don't we need to do that in every aspect of our life?
Yeah.
I assume I know exactly what my wife needs. She will be happy because I know everything.
You don't.
And you don't. and at the end of the day, what did somebody need from us as opposed to what did we need to share? So like on this podcast, for example, I have a lot of things that I'm like, man, I want to tell this, but it's not what the listener needs to hear. There's so much more value. And as a clinician, any kind of MD, chiropractor, PT, what did the patient need from me in that moment?
Yeah. So I want to talk about a few cases to really hit this home, that can help people really sink their teeth into just the information that we've shared and how to actually use it in real life, whether you're a therapist, whether you're a patient, like how does this actually work? And we can you've had a lot of cases that you've seen over the years, very severe, that have led to surgery, and you've guided that process. I've had way too many cancer issues in my young career that I've caught, But let's talk about some of these cases of what we call waitful watching in the PT world. I love waitful watching. So we're going to define waitful watching as the patient comes in, they have hard neurological findings. Hard neurological findings is just what we talked about earlier. We check their deep tendon reflex. It's diminished, meaning it's not the same as the other side, not nearly as jumpy, right? They have decreased sensation in a certain area, whether it be on their legs or their arms, and they have lack of muscle control. We'll simply define it as that hard neurological findings. What do? The eval, you're day one with them. How do you waitful watch as a PT?
I think that it's important to be conscious enough to not waitful watch when necessary, but in a lot of those situations, reassess, follow up with them, tell them the type of red flags that we're looking for. And my favorite thing, have patients journal. I have them write it down.
Yeah, what are the symptoms? Has it changed throughout the day? What activities bother it? What activities make it better?
Yeah, our memory actually decreases when we're in pain. So we're making new neuron synapses, new connections in our brain every day, every minute. And the amount of synapses that happen in our memory centers is significant, and it goes way down. So you've got to journal because they're going to forget.
I love that.
And just observe, keep observing, follow up with me in 2 days. Let's work on what we know we're safe to work on, and then
and
reassess.
There should be, with the exercises that we give you, they're going to be different for every person. A lot of people are like, well, just give me a bunch of exercises. No, there has to be specific for your particular type of back pain. But as we do those, we call it mechanical loading, right? As we do those exercises, there's a natural progression that we should see, right? Within a certain window. And I always tell people, say we had a 6-week program. I say, hey, this is the plan of care that you need. 50% better. We should be 50% better halfway through. 40 to 50%, somewhere in that realm. But there's a natural, we'll see these ups and downs, but it's still linear, right? And that's what we'll want to see over the next 6 weeks, that we're linearly progressing. Within a 6-week period, you should be 80, 90% better. And then we'll talk about weaning off till where you're doing this on your own, right? But what I love about back pain and any kind of these symptoms is there's this natural progression. And if you're not progressing, we know that you need to go a different route. And it's not anything that we should be prideful about. It's not anything that we should get heartburn about. I couldn't get my patient better. It's the science that failed, not us, right? We follow the science. There's this natural progression. If they don't progress, then we go a different direction, right? Is there anything else you add to the waitful watching? Any kind of important concepts there?
I just want to highlight what you said. Highlight that take that next step to refer to somebody else. I think as physical therapists, maybe I'm giving ourselves a pass too much on this, but we're at the bottom of the rung in the past, right? You go see a doctor, you get medication, then a doctor, then an injection, then a doctor, then surgery, and then PT. And so I don't mean give us a pass too much, but we need to wake up and become clinicians. We're primary care physical therapists now, right? So you need to be willing to, or actually anxious to, refer out. When you're doing that waitful watching, you're not seeing it follow the normal healing progression. 2 steps. 1, ask what else is going on. I've got fear that if I get better too fast, I have to go back to work. I hate my job, or whatever. The coach is trying to force me.
Will say that.
the coach is trying to do this, right, or whatever it is, and they're avoiding getting better. Or get them on, move them to get an MRI, referred to a specialist, an orthopedic surgeon, a pain specialist.
Yeah. Thing is, I'll share this last story, and then we're going to wrap up this podcast. But I've shared this story in the past. But I had that patient, mid-40s. Came in, visit 4, visit 5, just excruciating back pain. Things were getting a little better, but it was minimal. And I've seen hundreds of cases of back pain, and it just wasn't following the norm. And I couldn't even get her on her stomach. I couldn't get her on her back. We were doing all of our treatment and sitting, and she didn't have any red flags. So I'm like, right? But we were 7 visits in. She came in and said, I was laughing with my friends last night, and I just can't move anymore, right? So in my mind, immediately goes to Valsalva, right? which is technically one of the red flags. So when you Valsalva, when you're bearing down, if you have pain, that's something to highlight, right? And I immediately said in my brain, we need to get an MRI. Like, it's not following a natural progression. Keep in mind, this is 3 weeks into therapy. This isn't 12 weeks, right? We didn't see this thing till, kicking the can down the road that long. We make decisions early, right? And it wasn't following that progression. Ordered the MRI. She had 15 pathological fractures all down her spine. So many tumors throughout her spine. And, she had 3 little girls, and she ended up passing away 3 months later, and she could have got those. She ended up having bowel and bladder problems for years and never really addressed it. She kind of just pushed it under the rug. And I even asked her if she had bowel or bladder problems. She said no. But there's some cultural barriers there. But ultimately, that story is a very extreme example. And I hope we've given enough examples to know when you order the imaging and when you don't. There's certain reasons for it, and there's certain reasons you don't. We don't just order it for every single person. It's not necessarily the gold standard. It's helpful to us, but it doesn't give us all the answers. But going back to where we originally started, what is the question every patient should ask, Brad?
Every patient should ask, what do you mean as far as ordering the MRI?
Yeah.
Or
like, how does this finding match up with my symptoms?
Yeah, right? They need to ask, how does this line up with my symptoms, and what does my movement show in correlation with that?
Yeah, we're looking for the married correlation. We're not working for something that's not even what you're feeling, right? Does it match up? That's the question that you should consistently ask when you're getting imaging. So anything else that you hope our listeners know about imaging?
I'd just like to highlight one super important thing. Maybe this is more for physical therapists in general, but anybody who's been in a car crash, anybody who treats people who are in car crashes, there are the only other caveat, and I'm super excited to hear your thoughts on this because maybe you disagree with me on this, but there are times to order an MRI to tell a story.
Yeah, absolutely.
If you're in a car crash, you might not need the MRI for your treatment, right? But you need it to tell the story. How severe is it? Just because Brad says that it looks like this, and we're specialists in what we do, and our voice matters and our education matters, but sometimes you need this story.
Yeah, and just to add to that, I absolutely agree with you. Like, if you've been in a car accident, you have neck pain, you have back pain, an MRI is almost like absolutely necessary. Like, I would say the majority of cases are absolutely necessary and so important because you have to tell the story early on. Because if you need to go into a deposition, or like you're having a disagreement with insurance companies, with attorneys, you have to have that early picture, and it will really help the case so much if you do. So I agree with you there for sure. Okay. Well, thank you so much for joining us on the podcast today, Brad. It's been an absolute pleasure. I hope these tools, tips are so helpful for you as you navigate the healthcare system, because sometimes it gets a little messy, and we're here to help you navigate the complex system and get you answers and be autonomous with your thinking. So thank you so much for joining us today.
Yeah, thanks for having me.